Okay, why don't we go ahead and get started? We have a small and mighty crowd here in person and many more people online, so thank you all for coming today. Today, I think, is an extraordinarily important topic, and I'm thrilled that we have a visiting professor who is a world expert in it to address it. So, if anything, the past 3 years have taught us that that misinformation is one of the great problems in medicine and actually in society more generally, and abetted, of course, by the current media and social media environment. It's an age-old problem in medicine, and one of the key protections that patients have from misinformation is the idea of certain individuals being trained and having characteristics that allow them to be credentialed as experts. But even that is under assault and threat by different parts of our society. Where everybody can be an expert by going and doing a Google search or a ChatGPT search, and there is a general questioning of expertise in pretty much all walks of life. These are really complicated issues, extraordinarily important issues. I don't know of anybody who's thought about them more deeply than our speaker, and so we are thrilled to have Dr. Rich Barron join us. If you haven't had a chance to read his article in this week's New England Journal of Medicine, which has the same title as today's talk, Protecting Legitimacy of Medical Expertise, Combating Misinformation in Medicine, you should. It's an absolutely wonderful, very thoughtful piece. Rich is president and CEO of the American Board of Internal Medicine. He was a former chair of the board of ABIM and served on the ABIM Foundation's board of trustees. I had a chance to serve with Rich as a member of the ABIM board, and I actually hired him to be CEO of the organization when I was chair of the board the year after Catherine Lucy, our provost, was the chair of the board. So there's a lot of UCSF connections. Rich practiced general internal medicine and geriatrics for 3 decades at Greenhouse Internists, an innovative practice located in Philadelphia. Following that, from 2011 to 2013, he served as director of seamless care models at CMS in the Innovation Center, where he led efforts that related to accountable care organizations and primary care. Rich received his bachelor's degree in English from Harvard, his medical degree from Yale, and did his residency at NYU in Bellevue, and then served 3 years in the National Health Service Corps in rural Tennessee. So we're thrilled that Rich is here to visit us, both to give this talk and as a visiting professor for the last couple of days. And Rich, thank you and welcome.
Thanks so much, Bob. It is such a privilege to be here at UCSF with a number of my personal heroes, and you are high on that list. It was a privilege to be on the ABIM board with you. You've created so many things, the hospitalist movement, a thriving department here, and even this Grand Rounds, which I knew you had broken through when a colleague who is a medical director of a Blues plan in New Jersey said, well, the way I kept up on COVID was watching UCSF Grand Rounds and learning what the latest things were. So I feel truly distinguished to be joining this community, and thanks for those of you tuning in. So here's my title slide. We're not going to spend any time on that. Bob's already done it. Everybody with ABIM has a disclosure slide. The bottom line for all of you residents, fellows, or people doing MOC exams, I'm not going to share any exam information. Don't look for it in this conference. So we're not going to do that. What are we going to talk about? Well, we're going to talk about some things that that sort of fly under the radar for most of us who live in the world and just do our job every day. The history of licensing professional self-regulation. I know you all think about it every day when you get up in the morning. Why it matters. A historical tension between expertise and liberty. And I think that's going to be actually at the center of the conversation. We're going to talk about the current loss of trust in facts and expertise. And given that all of us in medicine earn our living by being experts, this is something that is pretty consequential for us. How and why misinformation is so tenacious and why facts alone won't turn the tide. So you could say, and some of our critics do say, that the American Board of Internal Medicine is in the business of selling certificates. And people, many people have called that a sort of corrupt enterprise. And how can you do that? You're out there selling certificates. Well, they actually don't appreciate that it's a pretty competitive space, this selling certificate space. This is a certificate on display where I buy fruits and vegetables in Chestnut Hill in Philadelphia. And the proprietor went online, sent them $20, became a master of mangoes. It's signed by Dr. Selmore Mango. And right, it's a joke. Like, we know it's a joke, it's great. But there are actually some other certificates you can get online that may not be quite as jokey. Here's one that you can become an ordained minister. This one costs more like $100 with the Universal Church. And if you get this, you actually have authority in most states. I don't know about California, but I do know about New York. You do have authority to perform weddings. And the person who was the one who performed the marriage ceremony on our son and daughter-in-law in New York State was a web designer, and he got his credential online. You all don't know Jane. That's my wife. That's our son, Zach. You don't know Jane, and you don't realize looking at this photo that she's actually wearing a wig. Because she is in the midst, when the wedding is happening, of aggressive chemotherapy for a horrible form of breast cancer. I actually didn't care who married our son. Some people might, who performed the ceremony, but I cared a lot who oversaw her breast cancer. And the idea that we can kind of do all this stuff online and we can get all these certificates, it's important to think about what they mean, where they come from, what's behind them, and how they came to be. So becoming a physician community in one slide. So the first medical society of the United States, because it was 1777, was Litchfield, Connecticut. And when they got together, not only did they drink wine and have meals and do whatever else they did in Litchfield, because they couldn't watch Seinfeld reruns, which I think Bob would have done, they also said, we're going to examine anyone who puts himself forward in Litchfield County to be a doctor for their fitness to practice. We see that as our core responsibility as the society here in Litchfield, Connecticut. And by 1830, all but 2 states in the United States had licensing laws, though at the founding of a republic, only 1 or 2 states had them. By 1830, all but 2 states had them. But here's the wow factor. By 1857, only 2 states were still licensing doctors. And I'm going to spend some time on that in a minute, but just moving forward, this is a kind of important story that somebody writing about the history of ABIM in the New England Journal in 1950 told of the AMA meeting of 1865, where the New York delegation came with a complaint. And the complaint was that there were doctors in New York who were claiming special expertise in heart disease. And they didn't actually have special expertise in heart disease, they just said they did. And in the words of the New York delegation, it was a naked attempt to grab patients. And the relief they wanted from the AMA was to declare claims of specialty expertise unprofessional. If you say you're a specialist, you'll be kicked out of the AMA, that's unprofessional. Well, the AMA did what organizations do, they appointed a committee. Took them 3 years. They came back in 1868 and they said, specialization isn't actually the problem. That can work. It can generate more knowledge. Patients can get better care. But self-declared expertise, we should be worried about that. Somebody should take responsibility for actually validating that somebody has expertise. Could have been a lot of different people. It could have been medical societies. It could have been state licensing boards. Could have been a lot of people. It wound up being boards in this country, at least with respect to specialty expertise. American Board of Ophthalmology was the first board, 1916. ABIM, created by joint action of the AMA and the American College of Physicians. Let there be a body that can distinguish people who are internists from people who just say they are. But I want to return back to this period. What happened in this 30-year period? How did we go from only 2 states licensing doctors, from all but 2 states licensing doctors to only 2 states licensing doctors? And is that something that could potentially be in our future? Well, let's start with, what does a medical license get you? Like, why does it matter to have one? In the 19th century, it got you the ability to sue to collect fees, which you might think is like, well, that doesn't sound so terrific. Like, why would I want to do that? But that's because it gave you the ability to charge fees. And more importantly, in the states that license doctors, it gave you the ability to practice without being put in jail. Well, it's a joke today, practicing medicine without a license can get you in trouble, but that was actually contested territory for a period of time. Well, let's look at what licensing does now. It does all those things, of course, but it also gives you the exclusive ability to get paid for medical services by government and private payers. People who don't have licenses can't do that. And it gives us the ability, you don't get into a hospital by talking to your travel agent. You don't book your MRI on Expedia. You do this, we control this, and this is by virtue of our licenses. So what were the arguments that people made to get rid of licensing over those 30 years? And as I recount them, I invite you to reflect on how much each of these arguments is part of today's national discourse about a variety of issues in medicine. Well, the split among doctors in the early part of the 19th century when this argument was happening was between the orthodox practitioners who typically used heavy metals, mercury and arsenic and stuff, and the botanical guys who went out and found herbs. So the first argument was there were 4 medical freedoms, and the first one was bodily freedom. If you license those orthodox people and kick out the botanicals, I'm going to have to put poisons in my body that I don't want to put. I should have control over my body. You, the state, shouldn't give an exclusive franchise to people who are going to make me do this thing I don't want to do. Bodily freedom. Next one, economic freedom. What do you mean I can't contract with anybody I want to contract with to be my doctor? Why would the state tell me who I can hire to be a doctor? Was the patient side of it. And the doctor side of it was, what do you mean I can't just hang out a shingle and say I'm going to start treating patients? Why would the state constrain my economic ability to do this? And one of the major arguments was, if we do grant licensure to doctors, they will get together, form a monopoly, and raise prices. Well, of course, we wouldn't do that. That would never happen. But that was a second argument. A third argument was freedom of inquiry. If you anoint those orthodox doctors, the botanical doctors are not going to go out and find the herb that will cure cancer. You're going to limit new knowledge. You're going to freeze knowledge where it is. You shouldn't do that. It's bad policy to do that. And the last argument was freedom of religion and conscience, basically the concept of who's the state to tell me who I get to have for a doctor. I ought to be able to exercise the same kind of freedom that I do in choosing a religion or a faith or a church. I ought to be able to do that. And what did the arguments look like? Well, when the states actually discussed license repeal, this is from a New York State legislative report, and it basically focuses on, hey, our population, it's used to taking care of themselves. They're intelligent. They don't want any protection. They just want freedom of inquiry and freedom of action. And this is pretty salient these days of people who say, I'm more worried about how you're going to abuse whatever authority we give you and interfere with our own ability to figure out what we need. And then, of course, Maryland says, oh, there's nothing to it. Anybody can do it. It's just a science of observation. This is the easiest thing going. We're just out there looking at what's happening. Why should the state do that? And then when New York actually did repeal their medical license, basically what they said was, the consequence of this repeal is you won't go to jail for practicing. And in fact, some research suggests that even the states that did have criminal penalties for practice, juries were invariably unwilling to enforce them because they believed that that freedom was a more important place to be. How did the Supreme Court uphold medical licensing? And the first thing I would say to you is, you probably don't even know that it took the Supreme Court to establish medical licensing, but it did in a case called Dent versus West Virginia, which is an 1889 case. And here's the story. Dent was an eclectic practitioner, and he practiced with his father in West Virginia. And West Virginia passed a licensing law, and they said there can be 3 paths to a license in West Virginia. You can go to an accredited medical school, a recognized credible medical school. They weren't accredited, but you can go to a reputable medical school and have a degree. You can present yourself to the licensing board of West Virginia and pass a test and meet their need. Those, or you can have practiced in the state for 10 years. Well, Dent had joined his father and had only been in practice for 5 years. He hadn't gone to a reputable medical school, and he wanted to practice, and he took him to court. And he said, "You're saying you didn't want to show up in front of the state licensing board." He said, "You are depriving me of a property right without due process. My father and I, this practice, we own it, we invest in it, I feed my family. You are saying I can't earn a living. You shouldn't do that." And they go to the United States Supreme Court, where Justice Fields says, yeah, every citizen can follow any lawful calling, and people are entitled to pursue the profession of their choosing. But unlike the Maryland legislature, this judge was persuaded that few professions are harder than medicine. And he says, due consideration, therefore, the society can protect itself by licensing doctors. The argument for the states to do this in 1889 was, yeah, those freedom arguments are there, but we think it's important for states to be able to protect their citizens. Of course, one of the most controversial things ABIM has ever done is moving from lifetime certification to time-limited certification, and the Supreme Court had some words about that. They didn't believe it would be a matter for serious discussion, that people periodically needed to demonstrate that they had stayed current. Trust me, for the last 10 years I've been at ABIM, this has been probably the issue that has generated the most heat, is discussions about whether people should periodically re-demonstrate it. But in 1889, the Supreme Court said this would not even be a matter for serious discussion, would that they were right. So let's fast forward to our current situation. And this is Tom Nichols' book, The Death of Expertise, came out 4 or 5 years ago. It's a really interesting book. I encourage you to read it. It's very readable. And it basically talks about the way that that authority broadly is under attack, and experts broadly are under attack. The word expertise actually enters the English language, expert in the sense in which we know it, enters the English language in the 1820s, where a court decides that somebody's word is going to be given more weight than somebody else's word in court, and that's an expert. And that's the first time that the term is used that way. But Tom Nichols says it's dying. And data suggest he's right, that confidence in institutions is declining. From 2021 to 2022, the medical system lost 6 points of confidence, but the high was back in the mid 60s, when we were in the high 70s of confidence in the population. We are the biggest loser of all institutions. I mean, everybody's lost, but we are in more trouble than most folks. And this has a partisan cast. That Republicans have less trust in the medical system, Democrats more trust, and independents somewhere in the middle. And I'm going to come back to that because that has some non-trivial consequences in what happens to people in this country. So what happens when we lose trust? What's the impact of loss of trust on COVID outcomes? And I hesitate, knowing this august group of people who know every piece of data about COVID, to pick a particular article. But one of my favorites coming out of the pandemic was the Lancet piece last year, where they tried to look across 130 countries for who did well and who did poorly with respect to COVID and what predicted it. And I am not going to show you any of the data tables, but I'm going to show you a couple of slides that summarize some of their conclusions. They started with the WHO Pandemic Preparedness Index, which was created after Ebola, and which was basically structural. It's like, if you have these things, then you are ready for the pandemic. Well, it turned out that countries having these things or not having these things was not predictive at all of how they did with COVID. Something that was predicted, and we're all doctors and we get this, was some various health risk factors in the population, demographic factors. These were things that were predictive of worse outcomes, death from COVID in the population. But the biggest predictor of all was, wait for it, trust. Now, I'm sure that they didn't have a perfect instrument for measuring trust, and I don't even know exactly what instrument they used, but they purported to say that there was some international survey across many, many countries of trust that people have in their government and trust that people have in their fellow citizens. And again, I'm going to spare you the tables, but the narrative money line summary is this. They said, if across the world we had achieved what Denmark had of levels of trust, which was within the 75th percentile, global infections would have gone down 12.9% for government trust and 40% for interpersonal trust. This idea, sometimes I envision us these days as like being in a movie theater where there's a fire and somebody says, I've been coming here for years, that's the way out. And a bunch of people are saying, why listen to him? What does he know? You should go this way, you should go that way. If you don't have trust, a lot of bad things happen. And then, of course, you all have seen these data. I can't be the first person showing it, but this is data generated by Brown of sort of modeling how many vaccine preventable deaths there were once there was a vaccine. And they mapped this across the US and West Virginia, for example, in places where people were not accepting vaccines, things did not reliably go so well. And I mentioned the partisan cast. This is a National Bureau of Economic Research paper that came out in October. And it basically looked at deaths from COVID before the vaccine based on party registration. That's what you see on the left side. This is in Florida and Ohio. And on the right side, after the vaccine, so before the vaccine, Republicans and Democrats in those counties were dying at the same rate. After the introduction of the vaccine, Republicans started dying there in the red at a higher rate than Democrats in a meaningfully higher amounts of death. And this is just another curve expressing this. So this stuff clearly has an impact on what happens in pandemics, in diseases, in confronting health issues of all descriptions. And so we got to pay attention to trust. And as we start to understand it, medical mistrust can be understood to be a social determinant. And my own thinking about this was advanced considerably when David Williams, a historian, sociologist, African-American studies at Harvard, spoke at the ABIM Foundation Forum a couple of years ago. And he pointed out that mistrust is not merely the opposite of trust. It's not just the absence of trust. That's an important thing. It's not just that they don't trust. And it's not just interpersonal trust. It is mistrust in institutions broadly, including hospitals and healthcare delivery systems and doctors. But most importantly, he frames it as a protective response. That if you have been a member of a population that has been poorly served by groups of people who put themselves forward as saying, we're here to take care of you, and they don't, well, it's actually a protective response to say, I'm not going to trust you. I better not trust you, because if I do trust you, bad things are going to happen. So we have a lot of reasons to think about what it looks like to deal with mistrust as healthcare institutions. What's it associated with? Well, it's associated with lower utilization of routine healthcare for sure when you measure trust in populations. It's associated with lower adherence to any medical regime when you're looking at adherence to medications and stuff like that. People who don't trust don't follow through on what their clinicians suggest. It is associated with poorer management of health conditions. A whole variety of health conditions have worse outcomes in populations with poor trust. Lower likelihood of engagement, long-term relationships with doctors, which many of us think is pretty important. And of course, it's associated with racial disparities in care and outcomes. So there's a lot of things under the umbrella of trust that relate to healthcare outcomes that we care about. But of course, all of this stuff about misinformation is happening in a transformed information ecosystem. And the next set of slides I'm going to share come from Renee DiResta, who's a researcher at the Stanford Internet Observatory, and has thought a lot about the way that the transforming communication infrastructure has happened. So these are all attributes now of the information ecosystem we live in. Every one of these things doesn't cost anything to publish. Audiences are consolidated in aggregate, algorithmic curation, which is pretty scary in the AI world, personalized targeting, which is a core thing that's being done. Put that together with network effects, engagement, which is the core business model. Ultimately, the platforms are what rewards the platforms is engagement. That's their metric of success. That's not a truth metric, folks. That's not an accuracy metric. That's not a scientific metric. That's a metric of what attracts attention, virality, velocity, gameable algorithms. If there's one thing I would want clinicians to take away from this talk, there's going to be another thing I'm going to want you to take away, but this one, influence and expertise have been decoupled. Okay, we used to think that because we were experts, we were entitled to influence, we were accorded influence, patients would listen to us, society would listen to us because we were experts. Folks, that world is a certain kind of over. And Renee argues the power to influence opinions increasingly is about the ability to diffuse effectively a message. And as we talk about strategies in healthcare for trying to combat misinformation, our colleague on the board, Vinnie Aurora, has a program, University of Chicago, where she's working on trying to get medical students to learn misinformation rebuttal communication skills. And part of it has to do with get better at creating tweets, get better at creating content that can play in this kind of space. The next series of slides come from a guy named David Scales, who's at a company called Critica. He's doing some work with Kathleen Hall-Jameson on infodemiology. And he talks about the way that the traditional public health communication ecosystem has been disrupted. And this is what it used to be. Well, the scientists, we do the research, we create scientific advisory panels, we publish it in journals and monographs to get it out there. Public health people, practitioners pick it up and embed it into recommendations. Healthcare workers start reading this and following it and starting to apply it. And we've talked for years of how long it takes for them to do that. Then the media and the journalists pick it up, and then it gets to the public. And this has been the sort of classic way that medical knowledge gets generated and enters the society. That, folks, has changed. And now what we have is this. We have networked real-time public health communication. Everybody knows everything at the same time. Everybody's talking to everybody at the same time. And the whole issue of who has privilege, who should be listened to, who should be attended to, is up for grabs in a way that it has not been before. And in this world where engagement is prioritized, and again, I know you all have heard about or seen this science paper, that misinformation spreads a lot faster. It's the stuff that really grabs attention. It's the stuff that really drives engagement, and all of those other factors. False news spreads a lot faster, and it isn't bots, it's people. And this is the woman who won the Nobel Prize, Nobel Peace Prize, a Filipino journalist, Maria Teresa. And she says, look, I spent my whole life as a journalist. I can't compete with lies. Lies and anger are going to, the truth is boring. And if all I'm doing is telling the truth, I'm just really, really, really in trouble. And then, where are people, what are some other consequences in this infodemic? The people who relied on, which source they relied on, if they were listening to their doctor, they were the ones getting vaccinated. If they're getting their information on the internet, they're more likely to be unvaccinated. That these information ecosystems really are deeply, deeply, deeply influential. So Renee put up a slide at this past summer's forum that none of us in healthcare had ever seen before. And this is the slide. And it is a network map. Hands in the audience, how many of you have seen something like this and know what it is? Okay, a few of you have, most of you haven't. So what this is the colors represent communities, and what makes them a community is they're on Twitter and they're talking to each other and they have a certain kind of identity. The orange community is the autism community, and the pink community is the anti-vax community. And so there used to be some dialogue between the autism community and the anti-vax community. But then the anti-vax community discovered the medical liberty and medical freedom arguments, and blue is the medical freedom cluster. It's the people who are prioritizing arguments about freedom and liberty, and teal is the Tea Party. And so you start to have this convergence between the anti-vax people and the liberty argument and the Tea Party. And the saddest thing on this graphic, folks, is green. That's the public health community. So the public health community is off talking to itself. It's not talking to the rest of these. She generated this graphic with the legislative fight here in California for Richard Pan's bill about immunization, required immunization. And it's actually what launched her career in this area. Was she became a mom who used these tech skills to map this stuff. And this is the kind of thing that can be done, but it's hugely resource intensive to do this work. Nobody's doing it. Some of us are arguing that this needs to be a core part of public health surveillance, just the way that we survey for diseases, epidemic diseases, we should be surveying for misinformation. So another thing to be aware of as we think about what it looks like to respond to these narratives is to realize that they fall into categories. There are typical narratives, and you'll hear them. These are the four broad categories: safety, efficacy, distribution, and conspiracy. So what are the safety narratives? Well, the vaccine is dangerous, and any number of ways that that's told. It alters your DNA, it makes you infertile, but that's a standard. The vaccine is dangerous. Similarly, the vaccine doesn't work. Well, they said you wouldn't get COVID if you got the vaccine, and then you did. Clearly, it doesn't work. Distribution narratives. Why does it exist? It's big pharma. It violates the Nuremberg Code. This is violate our freedom purely for profit. And then the conspiracy narratives. This is where things really get interesting. It's a bioweapon. It's a chip. It's something else is going on. And each of these narratives, you will recognize them, you will hear them from patients, and trying to understand and locate them in the larger narrative is an important way to go. This isn't news to any of you that established vaccine networks. They are now anti-vax networks. They're not stopping with COVID. Now it's about, let's roll back the school requirements for school vaccination and stuff like that. So they're going there. And then you get things like died suddenly, which is all of a sudden this sort of viral documentary of associating sudden death with COVID vaccine, whether it's on the football field and it's not just crazy people. Somebody on our board, father, had a heart attack at 80. He has a scientific background. He had a variety of reasons to be at risk. He asked his daughter a week later, do you think it's because I got the vaccine? It's a sticky kind of narrative. It's a scary kind of narrative. And of course, this political valence, it means that choices that people are making start to feel like political choices. The choice to get ivermectin is rage against the machine. It's declare yourself independent of pharma, show that you're not going to be controlled by government. Really? Like, that's the way we're going to tell that story? So, some pathways to trust. If I wish that I had, no, I'm sorry, before I talk about that. So what's some evidence that the counter narrative might be true? What's some evidence that actually doctors and healthcare delivery systems aren't trustworthy? Do you think high prices and medical bankruptcy might sustain and support that narrative? Do you think surprise billing inspires confidence and trust in our delivery system? Our collective failure to manage conflicts of interest, racial disparities, which are prima facie evidence. I mean, we can talk about Henrietta Lacks. We can talk about the treatment of the study of untreated syphilis in Black men. We can talk about those things and their history, and they're clearly very present. But how about right now? How about lack of access? And here's my favorite, that this is something I would want each of you to carry. Like, you go to work and you're struggling to get something done, and you're outraged, and you're mad at administration, and you're feeling like a victim, and you're feeling like, oh my God, I have to do this stuff. Well, how about your patients? Like, we can't get this stuff for them. Do you think that's evidence for them this is not a trustworthy system? So what does it look like to try to restore trust? What are some pathways to trust? I was worried about the number of slides that I had and that I wasn't going to manage my time right. This is the one that I wish I had more slides, because I don't have that much to tell you really at scale about pathways to trust. One, speaking against your own self-interest. Choosing wisely, the ABIM Foundation initiative was a man bites dog story. It's, wait, doctors are telling me not to do stuff. We all know that the surgeon we respect the most is the one who says, actually, we don't need to operate. So when people speak against their own self-interest, that is powerful. Unexpected messengers. The parents of a child with autism saying, Peter Hotez saying, you should get vaccinated. Autism was not, my child's autism was not related to that. This is one of my favorites that's underutilized. I think we can use technology a lot the way some online companies use technology, so that patients will be recognized wherever they're encountered in the delivery system. Being able to push forward things that are personally important to patients, how to pronounce their name, the names of their kids, the names of their pets, any of those things. These are things that get buried somewhere in the medical record, but we could use technology to help know people. Whoops, I went the wrong way. Saying something good about colleagues. We live in worlds with handoffs. If you say, you are so lucky, I'm leaving, but Dr. Jones is following, she's fabulous. I wish she would take, those kinds of things really help people manage that. Intentionally, systematically building relationships, which is what the foundation is focusing on, trying to get the healthcare delivery system to think about. And then, and this is, I'm going to close with this, connecting facts to people's particular predicament. I'm going to get back to that in a minute. So what's ABIM doing? Well, there are a few things: social media badge, some ABIM Foundation grants. We're trying to do some thought leadership in an internal article and others, and some disciplinary action, which I'll say something about in a minute. So the social media badge, one of the things that people are saying to deal with misinformation on platforms, people say, let's put more good information out there. Let's promote good information. So we're actually in discussion with YouTube about the possibility that we would give them a list of board certified doctors who have committed to follow principles of responsible social media communication. And we would say to them, as part of the pledge, if you violate this pledge, you'll lose the distinction. Those doctors would get a badge that would say something like this: I'm committed to sharing evidence-based information. It could be any of the ABMS boards. This could be woven into a video, and YouTube would algorithmically promote their content. Is this going to solve the problem? No, it's not going to solve the problem. I mean, if YouTube has an engagement model, the information dirty dozen, the top 20 doctors on YouTube, none of them are board certified in anything, and YouTube isn't going to get rid of that. But it's at least a way that we think we can put the credential out there. We've given some grants in internal medicine training. What's important about this is we got together with ACP, with the foundation, with AIM, with the MACP Foundation, and are giving, and Gordon and Betty Moore got in on this too, for training. And then we also looked for people who were doing innovative strategies of trying to combat misinformation at scale. We found this great organization, Fact Checado. They are basically targeting the Spanish-speaking population with some very innovative social media approaches, starting with they're not on Twitter, they are on other social media platforms in WhatsApp, and you need to be there if you're going to find them. And then I talked about the thought leadership. Zeke Emanuel and I wrote this piece in Stat at this point a year and a half ago about state legislative interference in doctors. And the Tennessee State Licensing Board basically was threatened with dissolution by the Tennessee legislature because they said, if you take disciplinary action against doctors who put out misinformation, we will dissolve the licensing board and appoint a new one. And where it landed was the state legislature said, you can only take action specifically authorized by the state legislature, which is kind of horrifying. The New England Journal piece that our board chair, Yul Edgeness, and I wrote last year, Do Right and Wrong Answers Still Exist in Medicine? And again, for us, the take-home message here is we may not always know what's right, but we sometimes can really for sure know what's wrong. This is the one that just came out today. Sure, I can make this timing happen anytime I want. Thank you, New England Journal. But the reception is mixed. The reception is mixed both in terms of the public and in terms of our colleagues. And Dr. Gibson is a cardiologist who does not think well of the American Board of Internal Medicine, and he has a Twitter poll. Do you think Barron? I only have one R in my name, but that's okay. What does he think? What's the result of this poll? Well, they don't think we should do it. Our surveys actually say that somewhere between 60 and 70% of the diplomats support our doing this. 30% don't. And in the lay population, a lot of millennials would say, I actually trust myself more than I trust you. I'm more worried that you're going to get me in trouble. So this is from Paul Starr's book and the Social Transformation of American Medicine. I'm not sure how many people are still reading it. The challenge he takes for himself is to explain how we went from an economically marginal community of doctors in this country at the time of the revolution to the economically prosperous, major, influential group we were in the 1980s. And what he observes about the 18th century doctors, he quotes Benjamin Rush, Molly Cook's ancestor, she's a descendant. He quotes Benjamin Rush as counseling his colleagues to plant a garden. Why should they plant a garden? They shouldn't go hungry, because then they'll have the improvident wish that a plague would strike the community so they could generate fees. That's the level of economic marginalization that doctors had in the 18th century. And Paul Starr says, how did we get to where we are? And he says, it was a community of shared standards. And a book on the Constitution of Knowledge by Jonathan Rauch basically says, scientific knowledge is never an I, it's always a we. Somebody has an idea, but what makes it knowledge, what makes it true, is when a community embraces it and decides, yes, that's right. You don't get to do it yourself. But that's not the world we're living in. Here is a language from a Supreme, wait a minute, I feel like I missed something here. Here is another Supreme Court case, the American School of Magnetic Healing versus McAnulty. McAnulty was the postmaster in Nevada, Missouri, and every day he delivered 3,000 pieces of mail to the American School of Magnetic Healing. What was in that mail? Checks and money orders and cash payable to the school for the magnetic healing services they were advertising in newspapers around the country. You send them $10 and they say, wherever you are on Tuesday afternoon at 3 o'clock, lie down, and we will channel the magnetic energy of the universe into your body from Nevada, Missouri, and we will heal you. Well, the post office looks at this and says, sounds like a fraud. And they hold a hearing and they decide it's a fraud and they stop delivering mail. And the school takes them to court. And they lose in the lower courts, but they go to the US Supreme Court where they win. And this is Judge Peckham's opinion. And he says, we don't really know how this stuff works. The mind, the body, electricity, magnetism. One doctor says it works, another doctor says it doesn't work. It's just a difference of opinion. There's no way to establish an objective medical fact, he says. So you can't call it a fraud. What kind of world is that? What kind of world is that with respect to what it looks like to be able to offer real benefits to patients? So here's correspondence and email from a diplomat in 2017, and he says, I don't need you. I'm fine. I'm a competent doctor, and I'm not ceding the authority for my ability to you or anybody else. And our public stuff going into the disciplinary space with doctors and saying we're going to send letters and potentially revoke certification from doctors who put out flagrantly false things, that put us on the Tea Party Patriots mailing list. And this is an email we got from hundreds of Tea Party patriots saying, we're not inferior to you, and what you're doing is a crime against humanity. And I don't know how many of you have heard the Nuremberg 2.0 trope, but the real extreme folks on this are saying that those of us promoting vaccination are committing war crimes, and when the power shifts and the real people are in charge, it's going to be Nuremberg 2.0, and we're all going to be go to jail or be executed. So what's our big path out of this? Well, we do have some expertise, and we might be tempted to say to our patients, I've got it here. I'm the expert. Don't confuse your Google search. But we should be alert to the patient response that says, actually, I've got some expertise here too. And, one way to think about it is we come into the room and we've got all this knowledge about drugs and technology and testing and anatomy and all that stuff. Okay, good on us. That's what we train to do. The patients, they come into the room and they actually have a bunch of expertise too in their own lives, in the situations in which they find themselves. If we're getting it right, what we're doing is trying to figure out how to use that expertise we have to the particular predicament and situation that they have. And that requires recognizing it, being curious about it, understanding it, connecting with it. Scientists don't have a predicament. They're just asking questions about things that may be true anywhere for anybody. Patients have predicaments. And as doctors trying to do scientific practice, we are best served when we connect the scientific knowledge we have with the predicaments that the patient has. And when that happens, this is me and Jane at 13,400 feet on our way to Machu Picchu a year after her diagnosis and treatment for breast cancer. She's doing fine, and I am grateful for the level of medical expertise that was available to treat her. And I hope we don't lose our collective grip on reality and figure out how to defend the science and defend the legitimacy of what we do. Thanks for your time today. Really enjoyed the opportunity to be here.
Thank you, Richard. That was superb, incredibly thought-provoking. Let me start with a few questions. Seems like the struggle that the boards are facing is the questioning of expertise, not just by patients, but by other physicians who are looking at the boards as yet another group of elites who don't really get what I do in my community practice. I know you struggle with that, and you have kind of a unique position as chair of the board, but you came at this from a community practice background, not an academic background. So how have you framed that, and how have you tried to address it?
Thanks for a really great question. And I think that what we learned at the board was that we had fallen out of connection with the community of doctors we were certifying. We were arrogant, we were distant, we were disconnected. We didn't even have, we had capacity to create tests and generate bills. We did not have a capacity to actually be in conversation with the community. So a lot of what we built in the last 5 or 6 years is the capacity to do that, which has been a combination of governance changes and staff changes to be able to be in more robust dialogue with the community that is practicing doctors. We've also done governance transformation where 47% of diplomates are international medical graduates. That hasn't been the representation on the board and in governance, but it is a lot higher today than it was before. So trying to move toward being an organization where the diplomates would see themselves, and for that to be authentic and true. And frankly, Bob, we think a lot of the lessons that we learned at the board in that journey are very relevant lessons for healthcare institutions.
Great. The board, not just ABIM, but others and state licensing boards talked a lot about medical and misinformation in the context of COVID and taking away people's licenses and taking away board certification, and then showed some of the backlash. Did any of that ever happen? And if so, what was the experience of doing that?
So the process, what we've done is we've gone public with some statements, and the previous New England Journal article in last June basically outlined the process we use to discipline doctors and outlined the criteria we would use and indicated our intention to apply it. it's a confidential process. And so we can't discuss and don't discuss individual doctors. And the only thing we ever say publicly about doctors, for better and for worse, is they're board certified or they're not. Some of the doctors who have gotten letters from us, as described in the article we published in last June or July, some of those doctors have gone public with the letters. And so it's a matter of public record that we are sending letters to people that say, we have some concerns and your certification may be revoked. Where we are in the process, how many people are involved, all that stuff is stuff we don't talk about. But again, it's the same way that doctor-patient confidentiality, that the patient has the right to talk about whatever they talked about with you, but that doesn't free you to then be able to talk about what you're doing with them. And that's where we are on this.
Open it up to questions anybody has. Let me see if I can get this to work, Catherine.
I watched it.
I'll repeat it.
Yes.
Say who you are.
Hi, Catherine Lucy. I guess I'm the provost of the University of California. Wait, what day is this?
No guessing.
No guessing.
Right.
Thanks for a great talk. Really thoughtful, and I appreciate the historical perspective and the warning about how quickly licensing can decay from all but two to only two. Some of the trust literature talks about trust propensity, the instinct of an individual or population to embed trust or have spontaneous trust in organizations. And I think David Williams' talk about mistrust in populations is really relevant to that. It seems to me that part of recovering trust or addressing trust propensity in populations is to acknowledge when our evidence base has harmed them. I mean, we have evidence-based medicine. Frankly, most of those evidence bases were acquired in predominantly white, predominantly male individuals, European individuals. And yet we sort of skip over that healing part, because an apology can go a long way, a sincere apology, a good apology, not like, I'm sorry you feel that way, but truly, there were people in the 30s, 40s, 50s, 60s, 70s, after board certification was present, who actually engaged in activities that caused mistrust. And I wonder what your thoughts are about the profession as a whole reconciling with that and taking the step to try and repair that relationship by acknowledging that, as you mentioned, a lot of things around distrust. Healthcare disparities wasn't on that list. I think it should be. And I think exploitation, marginalization are other things. And I'm wondering what you think about organizations and apologies.
So that's a great question, Catherine. And I think apologies are critical. And frankly, in my own leadership journey at ABIM, after I'd been there about a year and a half, I sent out an email to 250,000 diplomats with the ray line, "I'm sorry, we got it wrong." And apologized in the email for launching a program before it was ready and committing to work with them to make it better. Institutional apologies are tricky things. I think about the Milbank Foundation, which discovered that it had actually provided funding to the study of untreated syphilis in Black men. And when they discovered that, they went to Tuskegee, they identified descendants of the people who had been harmed. They did a very public apology ceremony, and they committed funds to various causes in Tuskegee to try to make restitution. I think the closest we have that's sort of scalable are the apology and reconciliation programs that go on in some healthcare delivery systems for medical error and harm directly to patients. And I think that's a really good paradigm to follow of to say to people, we are responsible for this harm. How you deal with historic harms is very challenging. And I think that it's a conversation that healthcare organizations need to engage in with the communities they have harmed. Part of what Milbank figured out was, if they were going to do anything to try to fix this, they had to get as close to the people they had harmed as they could to have the conversation. So I think there's no question that apology is a major part of it, not a, "I'm sorry you," and not an I'm sorry, people 30 years ago did something. But the other thing that goes with apology and was part of the ABIM apology was when we made that announcement, we said, and we're making this major change in our program because you've told us this isn't working. So you can't just say, oh, I'm sorry, let's move on. And I actually think that all the experience each of us have in relationships, in families, in whatever, where we do wrong, do harm, and then try to figure out how to make it right. I think those can be informative at an institutional level as well. And it's a great question.
To use the board prevent a descent down to the bottom in terms of the criteria. So the pressure from the community, like who first is partly who made you the boss of me, but secondly, I work really hard, I'm good at what I do, and you're giving me this test that takes a long time and it's very expensive. An easy response to that would be to dumb it down, to make it, to sort of lower the bar. So how do you balance what you feel like is your responsibility to patients with what is going to sort of enlist the crowd that probably doesn't want it to be as rigorous a process?
So again, great question. And the core for us is it needs to be a meaningful, relevant credential at the end of the day. Whatever value it has or doesn't have is about how meaningful and relevant it is. And so we have separated the idea of what I'd call user experience from rigor. And we've realized that it's possible to give a less burdensome, less difficult user experience without sacrificing psychometric rigor and assessment rigor. It's a subtle distinction, and it's one that many of our society colleagues have had trouble embracing, but it is something we're committed to. We believe the value we contribute is that summative decision. The second part of it, frankly, is opportunities like this to try to explain to people why it matters. Because if people don't think they have a stake in it, then they have no reason to want to do this. So it's a combination of making the process hit the ground in a more comfortable, bearable way, having it still preserve value, and trying to engage as best we can in getting across to people why this matters to them and not just to us.
I thank you for the. Oh, Nader Najafi from Hospital Medicine. Thank you again for the talk. It was very interesting. I had a question about, do we set sort of evidence thresholds at which something is known to be a wrong practice or misinformation? The reason I ask is, I feel like ivermectin was easier. There wasn't good data. Once the randomized trials came out, it became even more obvious. So that one felt a little bit more obvious to me as misinformation. But then I think back to my own residency in medical school. I mean, there were things that we did. We were putting in central lines to measure CVPs on everybody with sepsis. We were giving hormone replacement therapy like it was. So there were, I wonder if once we got evidence, more evidence, and we could see that those things were wrong, it got easier. So is it that we set sort of an evidence threshold? We say if it's got, I'm making this up, but some number of RCTs that are done with certain rigor, then we can say that something's right. Because sometimes I worry that in the moment, it's hard to know until we get better evidence,
Absolutely. And when if the board considers revoking certification from a doctor, you're guaranteed litigation. You're guaranteed an adverse process. You're guaranteed somebody who's going to say, you're going to be in court, you're going to be defending it, you're going to be. So the directions were, we need a really high bar. We need to not be in the place where people can have arguments about maybe this is okay. And the upside about that is you take defensible actions. The bad side about that is you leave a bunch of pretty bad behavior on the table, stuff that most people wouldn't do, that you probably think is a bad idea, but you don't think meets that standard. I wouldn't recommend that clinical practice people confine their decision-making to that space. You have to make decisions in areas where the evidence is unclear, and you're going to make the decision that you make, and you're going to make the best decision for that patient you can. What the board is trying to do is to define no, I'm sorry, this is just, no, nobody thinks this is right. And if you are continuing to say, this is true, continuing to offer advice to patients that if they rely on it, they're much more likely to be harmed than they are to be helped, we will regard that as violating a standard.
Thanks so much. Rita Redberg, Division of Cardiology, Department of Medicine. Great talk. I wanted to sort of continue on the theme of evidence-based medicine and trust and professionalism. And in particular, I think since Bob and I were in medical school, there's been a lot more money in medicine, and that with that brings a lot more conflict of interest. And frankly, what I see now in some of my profession and professional societies are clearly not evidence-based guidelines. And, and one has to always consider that there's industry support for these non-evidence. Like one example, there's now a campaign from the American Heart Association to screen for aortic stenosis, and there happens to be a very lucrative procedure associated with that. But I don't know of any data that asymptomatic people benefit from any of these procedures, and it's very troubling to me. Is that kind of thing the sort of misinformation that we should be considering in licensing, professionalism, or other sorts of board activities?
So I think clearly managing conflicts of interest better than we do is important. And being transparent where there are financial motivations and the evidence is shaky is important. Whether it's misinformation or not could be debated. When I look at the pushback we get, and I've seen tweets already from the article, Semmelweis is rolling in his grave. All of a sudden, all of these people out there who are like on the extreme, every one of them is Semmelweis. Every one of them is, really? Like, I don't think so. So we at the board are looking at the extremes for the purpose of being able to say there are some lines. Because I think what starts to happen once people say, well, this might not be true, so that might not be true, so the other thing might, and next thing you know, you're just sliding down this crazy space. So
just to get on Rita's question, does it really matter whether the reason you are promoting misinformation is you were motivated by money or you're crazy? I mean, is the misinformation the thing, or is the motivation the thing?
Well, it's often both, and very often both, and evidence for both. We decided not to use the term disinformation because it requires you to find intent, and we didn't want to get into intent. We wanted to stay with, is this objectively not true, and are you saying it?
Take one more. This is from Lakshmi.
1.5 questions from the audience of 100 watching live. One is, what is the role of the professional society in combating medical misinfo? That's from Dr. Nora Goldschlager. And another one is about, how do you deal with states differentially treating medical misinfo? For example, Simone Gold in California versus Joe Ladapo with the Surgeon General in Florida.
Right. So with respect to the first one, I think the role of societies, first of all, is to put out good information and make it accessible both to their members and to the public. I actually think it's the role of societies to champion the role of the boards in this. And that's a self-serving thing to say. And for the last decade, societies have been in a different place with respect to boards, channeling anger from members. And I think societies need to step up. And I was thrilled when the AMA published a misinformation policy paper last June, which explicitly called on certifying boards to take action against doctors. So I think societies need to support that, and they need to support it strongly, because they are actually the unexpected messengers in here. Societies saying, yes, the boards are doing the right thing would be a huge message here from an unexpected messenger that would be much more influential than anything we could say. So I'd say that. With respect to states, one of the things that happens with us is that we believe that we are emphatically not a government organization. We are not a state actor. And as a result, we're a private organization, and we basically get to say, as long as we're having some transparent process about it not being totally arbitrary, we get to decide who holds that certificate and who doesn't. And when that's been taken to court, which it has, thus far, we have won those arguments. States don't have that. States have the government, state licensing boards are government actors. And the question of state licensing boards, whether they have First Amendment obligations where if they're going to come after a doctor for something that the doctor says, is that a First Amendment problem? And then Michelle Mello, a law professor at Stanford, says, what do you mean? We regulate speech all the time, commercially fraudulent speech. You can go to jail for that. Why would we prohibit commercially fraudulent speech, but permit, in effect, medically fraudulent speech that is going to kill people? So that's an active argument right now, what the state licensing boards can do. But they are creatures, as Tennessee illustrated, of the state legislature. The state legislature empowers them. Often the governor appoints them. And when the showdown happened in Tennessee, the guy who was co-chair of the Government Operations Committee says, if you don't take that policy off your website, I will defund the medical board and appoint another. And the candidate for governor in Minnesota, unsuccessful, fortunately, said if he got elected, he would dissolve the medical licensing board because they were coming after him. So I think states are a more complicated thing, but I just wish the state legislatures would delegate that authority to the licensing boards and leave them alone, which they're not doing.
Richard, thank you for incredibly important, thought-provoking talk. And also, you, I think, have about the most thankless job that I know. I want to thank you because you do it incredibly well, and it's really good for internal medicine and really good for patients. So thank you.
Thank you.